Okay, so upper limb anatomy number 1. So first of all, the curriculum. So I've looked at the curriculum, and I would strongly encourage everyone to look at the curriculum, and it describes the content that you need to have, the areas that you need to understand for the anatomy. And it's very clinical, so it's all related to injuries in particular when it comes to neurology and conditions that you may see in emergency medicine. So they're not interested in pure anatomy in the sense that an anatomist would. They won't generally ask you about origins and insertions and relationships of muscles to blood vessels and so on. It's very clinical. Okay, so I'm going to start with the spinal cord because that's sort of where our journey begins. And the first thing I thought it would be useful to talk about was just to clear up a few things about roots and rami. So I'm going to play a little video, and I hope that this comes across okay. This picture shows a section through part of the spinal cord and also the nerve roots arising from it. And we're just going to deal with the issue of nerve roots and nerve rami. So here we are with the grey and white matter within the spinal cord visible, and also two roots arising from it, a dorsal root at the back and a ventral root at the front. Now the dorsal root contains sensory fibres and has the nerve root ganglia for the sensory fibres. The ventral root contains motor fibres. Let's add those in, and so we've got the sensory fibres in blue and the motor fibres in red. And we can see that the two roots meet again shortly after emerging from the spinal cord, and then they branch into the dorsal and ventral ramus. The dorsal ramus carries motor and sensory fibres to the back of the body. It's much smaller usually than the ventral ramus, and it provides sensation to an area of skin just either side of the spine. And usually the sensation for each particular segment is confined very much to an area close to where that segment arises. And again, the motor fibres just provide motor supply to the muscles around the spine, the muscles that basically maintain posture. And really the dorsal ramus does very little more than supply an area fairly close to the spine. The ventral ramus at each level, on the other hand, is often much larger and contributes to the various plexuses, so to the brachial plexus, lumbar plexus, sacral plexus, etc. And that carries sensory and motor supply to the rest of the body, the front of the body and the limbs and so on. The final two little roots that we need to look at the bottom here are the grey and white rami communicantes. Now we'll look at those when we talk about the sympathetic nervous supply, and those meet with a ganglion at each level, and those ganglia from T1 to L2 communicate vertically with each other and subsequently communicate with the three sympathetic ganglia in the neck. Okay, so that's just clear up this issue about roots and rami, because you have dorsal and ventral roots, but you also have dorsal and ventral rami, and from now on, in a sense, all that we can concern ourselves with relate to the ventral rami. Okay, so having cleared that up, that it's the ventral rami we're concerned about, then let's focus on C5 to T1. Those are the ventral rami that constitute the brachial plexus. Now, from the college's point of view, we don't need to know a great deal of detail and to be able to say that C5 runs in the posterior cord and so on. We don't need to know that sort of level of detail, but we do need to have a sense of the overlying structure, the fact that brachial plexus runs through the axilla, and some knowledge of how it relates to the injuries, which we're going to come to in a minute. So I'm going to just again play a short video that I recorded earlier, just going over the structure of the brachial plexus in a simplified way.
Brachial plexus. It starts as the 5 anterior roots from the neck, C5, C6, C7, C8 and T1. And those roots, those anterior roots, then combine to form 3 trunks. Let's take a new colour. So C5 and C6 join together to become the upper trunk. C7 carries on as the middle trunk, and C8 and T1 combine to form the lower trunk. and then you have your trunks. Next thing that happens after the trunks is the divisions. Let's get another colour. And each of these trunks divides into 2 divisions. So let's have 2 divisions from each of those. An anterior and a posterior division from each trunk. And what happens now is, I'm just going to grab another colour, is that those divisions then combine to form chords. And let's take the posterior divisions. Let's take this posterior division, and this posterior division, and this is a posterior division, and those all combine together to form the posterior chord. Okay? The anterior divisions of the upper 2 trunks, they become the lateral chord. And then finally, the anterior division of the lower trunk, that's going to become the medial chord. Okay, so at the end of that, we have a lateral chord at the top, posterior chord, and a medial chord. And those chords are then described with respect to the axillary artery. And the next thing that happens after that, and let's just grab a different color again, is that we then have what are known as the terminal branches. So if we start off with the posterior chord, that has 2 terminal branches, a smallish one, which is going to become the axillary nerve, and a large one, the radial nerve. The lateral chord, that has one terminal branch that becomes the musculocutaneous, and another branch that's going to join with the main one of the 2 branches from the medial chord to form the median nerve. And then finally, the other terminal branch of the medial chord is going to become the ulnar nerve.
So that's the basic structure of the brachial plexus, and we'll be referring back to that a little bit as we go on. So let's look at some brachial plexus injuries, because that's the sort of thing that can come up in the exam. So first of all, if you look at this diagram here, this is showing what happens to cause an upper brachial plexus injury. If you can imagine a force pushing the head one way and pushing the shoulder another way, then that can stretch the upper roots, in particular C5, C6, and where they join together. And that is the root of upper brachial plexus injuries. That can happen at birth. So for example, remember your obstetrics, and if you have a baby with shoulder dystocia, you may have to move the head one way and another to try and get the shoulders out of the birth canal. And that action can cause damage to the upper roots. And it can also occur from high-speed trauma. So your motorcyclist who's come off his motorbike, landed on the road, head pushed one way, shoulder pushed another way, stretching the brachial plexus and tearing the upper roots. And a brachial plexus injury causes Erb's palsy. So Erb's palsy, which is what's shown in the picture here, arises from a weakness coming from an injury of C5 and C6 level. And that particularly tends to affect the biceps and brachialis and the deltoid. Those are the muscles most affected, so the person can't abduct their arm and they can't flex at the elbow. And they also end up with this deformity of the wrist, which is known as the waiter's tip position, with the hand flexed at the wrist and pointing backwards. So this is the classic Erb's palsy. If it happens early in life, so in childbirth, the arm is also smaller because neurological lesions cause an undergrowth of the area affected. So a leg or arm with a neurological problem in a very young child will not develop fully. So they also have a smaller limb that's also wasted, and they'll also have a squared off shoulder because of the loss of the deltoid. So that's an upper brachial plexus injury. They vary in their severity, but they tend to be total injuries generally. Lower brachial plexus injuries, there's 2 methods that when these can arise: trauma in adulthood and trauma at birth. And the classical way of getting a lower brachial plexus injury is someone who's falling and suddenly grabs something, grabs a branch or something, pulling the arm suddenly upwards, and so there's a sudden stress on the lower brachial plexus roots, and that can cause the C8-T1 lesions. It can also arise in childbirth when the arm is grasped in a complex obstetric maneuver and pulled in this similar sort of way. You can get a lesion of the lower brachial plexus. The classic lesion from a lower brachial plexus injury is known as a Klumpke's palsy. It's C8 and T1, and so as we'll come to later, that's particularly associated with the hand. So they tend to get a claw hand and weakness of the intrinsic muscles in the hand. So those are the two commoner types of brachial plexus injuries. Brachial plexus injuries can also affect the sympathetic supply. So I thought it would be useful to talk about Horner's syndrome. So if you think back to your white and grey rami communicantes that I showed in that section of the spinal nerves, you have the nerves going to the ganglia are the sympathetic nerves. And so from the sympathetic chain in the thorax, T1 to L2, nerves ascend through a series of 3 ganglia in the neck. So these are the stellate ganglion, the middle cervical ganglion, and the superior cervical ganglion. And they only receive their supply from below. So it comes up from below and travels up in the sympathetic chain. And beyond the superior cervical ganglion, the sympathetic nerves travel in the walls of arteries and spread throughout the head, and ultimately in particular reach the eye, which we're going to talk about. So if we think about where lesions could occur and cause a Horner's syndrome, it could be in the spinal cord as it descends. It could be in the roots as they come out. So here's, I've put in some roots at the side here. They come out of the the spinal cord, and that could be damaged in a brachial plexus lesion. And then they could be damaged as the nerves travel towards the stellate ganglion, and this is where your Pancoast tumor, so a tumor in the apex of the lung, can invade the nerves at the base of the neck and affect the sympathetic flow into the stellate ganglion. They can be damaged iatrogenically, for example, by nerve blocks and so on in the sympathetic chain in the neck. And they can also be damaged if there's an issue with the carotid artery. So, for example, a dissecting aneurysm of the carotid artery can interfere with the sympathetic chain. So, Horner's syndrome can be caused by all of those. And what does a Horner's syndrome give you? Well, the classic description is it makes a series of things smaller. So it makes the what's called the palpebral fissure, the opening of the eye, smaller because of the sympathetic innervation to the upper eyelid is lost, so the eyelid drops down and they get ptosis. It also causes a loss of the dilatation effect in the pupil from the sympathetic nervous supply, so they get miosis. It also causes a loss of sweating from the affected side of the face, anhidrosis. And because of an effect on the muscles around the eye, they also get enophthalmos, and the eye sinks in. So just going back to the causes of Horner's syndrome, it can be caused by a lesion within the cord itself, particularly syringomyelia, which tends to affect the part of the cord that carries the sympathetic fibers. It can be caused by brachial plexus trauma, by Pancoast tumors in the apex of the lung, carotid artery dissections, and there are various iatrogenic means of Horner's syndrome as well. Okay, so we've talked about the roots and the rami from each spinal level. We've talked about the structure of the brachial plexus, and we've talked about Horner's syndrome. Let's go on and look at innervation of particular muscles around the shoulder. And I'm only going to look at some of the major muscles now, and we're going to look at some other muscles later. So first of all, looking at the from the front, and I'm just going to talk about these 4 muscles here: deltoid, serratus anterior, and pectoralis minor and major. And again, I'm just going to play another video about the main muscles at the front of the shoulder. There are four muscles around the shoulder that we need to think of when looking from the front. First of all, there's the serratus anterior. So this muscle is attached to the medial border of the scapula and then winds around the chest wall before attaching onto the ribs 1 to 8. And it's innervated by the long thoracic nerve, which is a branch of the brachial plexus. The long thoracic nerve is very vulnerable. It just lies over the surface of the muscle and can easily be injured in sports. For example, when the arm is raised up, a blow to the side of the body can damage the long thoracic nerve. But medically, it's also vulnerable in surgical procedures, surgery on the axilla, or the insertion of a chest drain. And because it runs behind the mid-axillary line, that's why we always put chest drains in anterior to the mid-axillary line to avoid damaging the long thoracic nerve. If the long thoracic nerve does get damaged, and as a result of that serratus anterior is impaired, then that is the cause of winging of the scapula, when the scapula swings out when the hands are placed against a wall. So that's serratus anterior. Let's move on to the next muscle that we're concerned about, and that's pectoralis minor. And that arises from ribs 2, 3 and 4 and attaches onto the coracoid process. Clinically, it's not a terribly important muscle. Its job is to pull on the coracoid process, depressing the corner of the scapula and pulling the shoulder forward. It's innervated by the medial pectoral nerve, which comes straight off part of the brachial plexus, one of the cords. So that's pectoralis minor. Pectoralis major is a much bigger muscle. It comes off the medial part of the clavicle, the sternum, and also from some of the ribs and the fascia over the ribs. And it attaches as a large tendon onto the medial side of the proximal humerus, important and a powerful muscle. And it's also innervated directly off the brachial plexus from the medial and lateral pectoral nerves. Again, those nerves are seldom damaged clinically, and so it's not an important issue from us from a neurological point of view. The final muscle we're going to look at from the front here is the deltoid. Now the deltoid muscle, we'll also look at it from the back, arises from the lateral part of the clavicle and also onto the acromion. It is innervated by the axillary nerve. Now the axillary nerve arises from the brachial plexus along with the radial nerve. It comes off the posterior cord and it passes through the axilla and winds round the back of the proximal humerus just below the head, and it can be damaged in shoulder dislocations in particular. So axillary nerve injury is clinically important. The axillary nerve innervates three things we need to be aware of. It innervates the deltoid, it innervates teres minor, and it also innervates an area of skin over the upper outer aspect of the arm, known as the regimental badge area, because it's where you'd wear a badge on a uniform. And so if the axillary nerve is damaged, we'd get a loss of sensation in that area, and also ultimately the deltoid would waste away if the nerve injury didn't recover. So those are the muscles and their innervation from the front of the shoulder. Okay, looking from the back, I'm going to look at three particular muscles at the back: the deltoid, trapezius, and latissimus dorsi. If we think about the muscles and their nerve supply when looking at the back of the shoulder, let's start off by looking at the deltoid. We talked about the deltoid at the front arising from the lateral end of the clavicle, and from the back it arises from the acromion and also from the spine of the scapula, and the fibers descend downwards on the outer side of the humerus before attaching to the tubercle of the humerus, which is just a little under halfway down. And as we will talk about more when we look at movements of the shoulder, the deltoid takes the arm in abduction beyond about 15 degrees. So the first 15 degrees is supraspinatus, and then the deltoid takes the arm from there up to a right angle before scapulothoracic movement takes the arm the rest of the way up to the vertical, and that's done by the trapezius, which we'll look at it next. So trapezius arises from a long origin right the way up just below the base of the skull at the top of the cervical vertebrae, attaching to the spinous processes all the way down to T12. So it has a long origin, and then its fibers move laterally before attaching onto the spine of the scapula. The action of the trapezius is to pull the spine of the scapula and rotate it. So rotating the scapula so that the top of the scapula moves medially. At the same time, serratus anterior, which isn't shown here, attached to the medial border of the scapula, is able to take the lower part of the scapula laterally. So the lateral movement of the lower part and the medial movement of the upper part act to rotate the scapula. Now the trapezius is innervated by one of the cranial nerves, by the 11th, by the accessory nerve, and so it isn't affected by brachial plexus injuries and so on. It is innervated directly from the head. We test the trapezius as part of our cranial nerve examination. So when we assess the 11th nerve, we ask the patient to shrug the shoulders, and effectively by testing trapezius, we're testing the 11th nerve. The final muscle from the back is latissimus dorsi. This is a large and powerful muscle which arises from the spinous processes from the lower thoracic and lumbar spinous processes and the fascia at the back. And then it winds around the side of the body. It actually overlaps the base of the scapula before inserting into the medial aspect of the humerus. The latissimus dorsi is innervated by a nerve that we don't talk about a lot called the thoracodorsal nerve. It's also known as the long scapular nerve, and it's not a nerve that's particularly vulnerable to injury. The latissimus dorsi is of interest because it's one of the few muscles involved in movement of the upper arm that's independent of the scapula, so it bypasses the scapula directly, binding the arm to the spine. Okay, so those are the muscles from the back, and I just wanted to go over these sort of outer muscles of the shoulder because of their individual nerve supply, particularly the deltoid, and how that relates to potential questions about neurology. Now, there are other muscles around the shoulder that I'm going to look at in a subsequent webinar: supraspinatus, infraspinatus, subscapularis, teres minor, teres major, which I'm not going to cover now, and which are not so vulnerable in any case to nerve injury. Okay, so let's move on to talk about we've looked at the brachial plexus as far as its terminal branches, and now let's look at each of those in turn and what each of those does. So first of all, the median nerve, and we'll look at the course of the median nerve in a moment. So the median nerve, I've looked to try and make things fairly straightforward in this, to keep things simple. So the median nerve, it doesn't innervate any muscles in the upper arm at all. Its first muscle is the pronator teres. So the median nerve is responsible for the most powerful, most important pronator, pronator teres. So pronation, which is the movement of the palm of the hand backwards, is a median nerve function. We'll see later. A radial nerve is responsible for supination. And then in the anterior forearm, so if you look down at your arm, it's all the muscles in your anterior forearm except for two are innervated by the median nerve. Those two are flexor carpi ulnaris and half of flexor digitorum profundus. Now, if you remember, you have two flexors that go from the forearm to each of the fingers. Flexor digitorum profundus, which goes to the end of each finger, to the terminal phalanx, and flexor digitorum superficialis, which goes to the middle phalanx. So part of flexor digitorum profundus is innervated by the ulnar nerve, and that's effectively the medial border, the ulnar side of the forearm is innervated by the ulnar nerve. The median nerve also innervates the thenar muscles. Those are the muscles for the thumb and the lumbricals, and it's also responsible for an area of sensation on the hand, which we'll come to later. So here we are with the median nerve runs down the medial side of the forearm in conjunction with the brachial artery, and it doesn't provide any innervation in the upper arm at all, either sensory or motor innervation. and it runs down until it starts to come across the antecubital fossa, the front of the elbow, when it gives off its first branch, which is to pronator teres, one of the two pronator muscles. The median nerve is responsible for both of them, so it gives off a branch to pronator teres and then crosses the antecubital fossa before passing into the forearm. Now, all of the forearm, the anterior forearm, the flexor muscles are provided by the median nerve except two. So they're all provided by the median nerve except two. The two exceptions which we need to remember are the ulnar flexor of the wrist, so flexor carpi ulnaris, and the deep flexor of the fingers, flexor digitorum profundus, the ulnar two parts of that, the ulnar side of that, which is also supplied by the ulnar nerve. So these muscles are both on the ulnar side, they're both on the medial side of the forearm. Okay, so that's the median nerve. So what about median nerve damage? When do we get median nerve damage? Well, of course it can be damaged anywhere along its path under certain circumstances, and it can be damaged by supracondylar fractures. That supracondylar fractures tend to occur in children, late part of the first decade, particularly common in girls, and of course they can injure the brachial artery, but they can also injure any of the three major nerves, radial, median and ulnar. But probably the commonest source of median nerve problems is carpal tunnel syndrome, and we're going to look at that later when we get to the wrist and the hand, and that's where you get compression of the median nerve, and that's really the main median nerve lesion. Let's move on to the musculocutaneous nerve, which has a similar origin in the brachial plexus to the median nerve, and from our point of view it really only concerns the upper arm. It deals with the motor supply to three muscles: biceps, brachialis, and a small muscle called coracobrachialis on the medial side of the upper arm. It also has some sensory supply below the elbow, and we won't need to worry too much about that because clinically we'll cover that through the issue of dermatomes. But those are the only muscles supplied by the musculocutaneous nerve. So again, I'm just going to talk about the path of the musculocutaneous nerve. The musculocutaneous nerve is not one that we worry about clinically very much, and injuries to it are relatively unusual. This is its path through the upper arm, so it comes from the brachial plexus in the axilla and descends down over the front of the humerus. If we compare it to the position of the median nerve is more medial, and so the musculocutaneous spreads laterally, but its motor supply all comes off in the mid-upper arm, and it supplies three muscles: the biceps, the brachialis, and the coracobrachialis. So let's look at each of those in turn. So it's responsible for the brachialis, which arises from the humerus and attaches onto the ulna. It's responsible for the biceps, which has two heads, one which arises from above the glenoid, which is the long head and runs round over the top of the head of the humerus, and the other is the short head, which comes off the coracoid process. And we'll come to the coracoid process in a moment. So that's the biceps, another muscle innervated by the musculocutaneous, and the last one is the coracobrachialis. This is just a little muscle that comes off the coracoid process and attaches on the medial side of the humerus about halfway down. So there are three muscles, in fact, that come off the coracoid process. There's the pectoralis minor, coracobrachialis, and the short head of biceps. So those are the muscles innervated by the musculocutaneous nerve. Now, in terms of lesions to the musculocutaneous nerve, they're pretty uncommon as direct lesions. Of course, it can be very much affected in an Erb's palsy, as we mentioned earlier, because that's placed higher up in the brachial plexus, and that can affect brachialis and biceps. But in and of itself, the musculocutaneous nerve is not particularly vulnerable. Okay, let's move on to the next nerve, the ulnar nerve. Just like the median nerve, the ulnar nerve doesn't innervate any muscles in the upper arm, and it's responsible just for two in the lower arm, in the forearm. and those are the ones we touched on them earlier with the median, it's flexor carpi ulnaris, and half of flexor digitorum profundus. And then it really comes into its own in the hand, where it's responsible for all of the intrinsic muscles of the hand, except for the thenar eminence, which is the thumb, and the lumbricals. And we'll look at all those separately. And of course, it also has a sensory function. So again, let's look at the course of the ulnar nerve.
The ulnar nerve arises from the medial cord of the brachial plexus. This has originally come from the lowermost roots of the brachial plexus, C7, C8, and T1. And so the medial cord becomes the ulnar nerve, and it runs down the medial side of the upper arm, posteriorly on the medial side, but it doesn't give off any motor or sensory branches in the upper arm. Gets to the elbow and it goes round the back, and I'll just put that down as a few dots, around the back of the medial epicondyle, and this is where it has a very superficial course just under the medial epicondyle, and it's quite vulnerable there to injury, and hence the whole paresthesiae from pressure on the medial aspect of the elbow, and the whole funny bone, knocking the elbow, causing odd sensations in the hand. So that's the ulnar nerve in the coming around the back of the elbow on the medial side, and then it travels down in the forearm in conjunction with the ulnar artery before reaching the medial aspect of the wrist on the volar, the anterior aspect of the wrist, and we'll come to that in a minute. And now in the forearm, it gives off two muscular branches, one to the ulnar flexor, the flexor carpi ulnaris, and one branch to the deep flexor of the fingers, but only to the medial half of it, the flexor digitorum profundus, the medial half, which are responsible for the fourth and fifth fingers, the ring and little fingers. So those are its two muscular branches, and it also gives off a branch a sensory branch to the back of the hand before it gets to the wrist, and we'll come back to that a little bit later when we talk about injuries. So a sensory branch runs off to the back of the hand. The ulnar nerve is yet again quite superficial where it goes through the wrist. It doesn't go through the carpal tunnel, it's more medial than that, and it's near where the ulnar pulse is, and it goes through a small tunnel and into the palm. Within the hand, it is responsible for nearly all of the muscular innervation within the hand. The median nerve, of course, is responsible in the hand just for the thenar eminence, for the opponens, for the abductor pollicis brevis, for the flexor pollicis brevis, and the lateral two lumbricals, number 1 and 2. But the ulnar nerve does everything else in the hand. So it's responsible for the hypothenar muscles, and it's responsible for the medial two lumbricals, and it's responsible for the palmar interossei, and also for the dorsal interossei. And it's also responsible for the adductor pollicis. So the fourth short muscle of the thumb is the adductor pollicis, which is innervated by the ulnar nerve. It's also responsible for the sensation over the medial 1.5 fingers, the little finger and the medial half of the ring finger. And of course it's responsible on both sides, but we've already talked about how the dorsal sensory supply comes off earlier from above the wrist.
So what about lesions of the ulnar nerve? Well, the commonest place for the ulnar nerve to be damaged is at the elbow. In fact, the ulnar nerve is very superficial at the elbow, and if you've never done this, you can feel it. You can actually feel it through the skin by feeling just next to your medial epicondyle. You can actually roll the ulnar nerve, and of course, if you bash your elbow, you can get paresthesia down your forearm, and that's the origin of terms about the funny bone and so on, because when you hit the elbow, you can get this funny feeling. So arthritic problems and injuries of the elbow and so on, degenerative disease of the elbow, is the commonest cause of entrapment of the ulnar nerve and damage leading to ulnar nerve lesions. So that's by far the commonest. But the ulnar nerve is also vulnerable to trauma, to blunt and penetrating trauma. So it's again fairly superficial at the wrist, on the medial side of the wrist. If you supinate your wrist and look at it, very close to the ulnar pulse. And so it can be injured by cutting at the wrist, a stabbing injury, and of course it can be damaged at other places in its path in the forearm. So ulnar nerve lesions cause a claw hand. We'll look at it more closely when we look at the hand. And the claw hand, oddly, tends to be worse with more distal lesions. If you have a more proximal lesion, so if you have a lesion at the elbow level, then you lose the flexor component of you don't have flexion of flexor digitorum profundus. And so the two fingers will tend to be more an extension, the ring and the little finger. But if you have a more distal lesion, then you will maintain flexion in the flexor digitorum profundus and tend to have more flexed fingers. And so this is what's known as the ulnar paradox, and explains why, at least visually, the impairment of function looks worse with a more distal lesion, which is, again, paradoxical, not what you'd expect. And this deformity is sometimes referred to as the hand of benediction, because it's the sort of the symbol that a bishop might make when making a blessing, with the two fingers stretched out like that. So that's ulnar nerve lesions. And let's move on to the radial nerve. Now, the radial nerve is responsible for the back of the arm, both above the elbow and below the elbow. And it does really everything at the back of the arm. So it does the triceps, and it also does the brachioradialis. Now, the brachioradialis, although if you look at a picture of an anatomy book, you can actually see it at the front. It's considered to be a posterior compartment muscle. It runs sort of pretty much down the lateral border of the arm. And the brachioradialis is also sometimes known as the long supinator, because it has a supinator function. It's one of two supinator muscles. The other one is just called supinator. So because both of them are innervated by the radial nerve, if you lose the radial nerve, you will lose the power of supination, and the arm will become pronated. That is, the palm will face backwards. So if you have a question about supination and pronation and the radial nerve, that's what they're driving at. It also deals with all of the muscles in the back of the forearm, and those are all the extensors of the wrist, extensors of the fingers and of the thumb, and also of the abductor pollicis longus. So the other side, ulnar and median nerve, deal with all the flexor muscles, and the radial nerve deals with the extensor and the long abductor. And of course, it also has a sensory role as well.
Okay, let's look at the course of the radial nerve in the arm, behind the axillary artery, from the posterior cord. And very early on, the axillary nerve comes off, and then the radial nerve carries on and goes round the back of the humerus. And in the course of its travel, let's just do that as dotted lines around the back of the humerus. It gives off branches to the triceps muscle. So it gives off branches to the triceps muscle as it goes around the back of the humerus. Triceps muscle, of course, producing extension of the elbow. And then it appears in the lateral part of the arm, runs down the lateral part of the arm. And during this part, it gives off branches to the brachioradialis and also to the extensor carpi radialis longus and brevis. So those are the wrist extensors on the radial side. There's a wrist extensor on the ulnar side, which we'll come up to in a minute, but just around the elbow, it gives off the wrist extensors on the radial side, that's longus and brevis, brachioradialis, and it also gives off a long sensory branch which runs under brachioradialis and ends up going around the back of the wrist and going into the hand and provides sensation. So the sensation in the hand comes off quite high above the elbow. Okay, the radial nerve, after giving off its sensory branch, a deep branch passes down in front of the radial head and then penetrates through the intraosseous membrane and becomes the posterior intraosseous nerve. And then it's largely motor from then on, and it's in the posterior compartment of the wrist where it gives off a number of branches to wrist extensor muscles. So if we just go through those, it gives off the branch to supinator, and it gives off the other wrist extensors, the extensor carpi ulnaris. And then let's think about the finger extensors. There's three of those really. There's extensor digitorum, extensor digiti minimi, extensor indicis. It also gives a branch to one abductor, the abductor pollicis longus. Okay. And it also has the extensors for the thumb, extensor pollicis longus and brevis. So all of the posterior compartment muscles are innervated from this deep branch of the radial nerve in the back of the forearm. Okay, and the sensory supply, as I say, and I'm going to do it in dotted down here, has come off just above the elbow.
Radial nerve lesions, questions can come up about that. And the best known radial nerve lesion goes under this rather strange name of Saturday night palsy. And the principle behind this particular lesion is that if someone's come home on a Saturday night having had far too many drinks and is too drunk to go up to bed, they might fall asleep in a chair. And in doing so, they may have the arm over the back of a chair, and pressure on the radial nerve against the humerus when sleeping can cause damage to the radial nerve. Of course, somebody who is awake and alert, they'll keep moving around, but someone who's sedated by alcohol or any other drugs, they don't move normally, and so they can get pressure effects, and so they can get it's usually just a neuropraxia. That means a temporary, usually lasts for a couple of days. But that's what's known as a Saturday night palsy, and that will lead to a loss of function below the level of the lesion. It tends not to affect the triceps. It's usually too low to affect the triceps, but it will affect the muscles in the posterior aspect of the forearm, and so it will cause a wrist drop and a loss of extension to the fingers. That's a Saturday night palsy. It can also come from direct trauma and also from supracondylar fractures. Okay, now I'm nearly at the end of what I'm going to cover today, and just before I do so, just to cover a little bit of neurology in terms of clinical examination. So you may well be asked about a question about root values and loss of reflexes. So we really only usually clinically do two reflexes in the upper arm, the biceps, which is C5 and 6, and the triceps, C7 and 8. But it's also worth being aware of the brachioradialis, or the supinator reflex as is often known. This is usually done with the elbow at a right angle, gently supporting the arm, and then using the patella hammer and tapping on the radius just proximal to the wrist. And that may elicit a jerk from the supinator, known as a supinator jerk. And finger jerk, this is a flexor jerk, and that's done by getting the patient to cup their hands, and then with the examiner's fingers intertwined with the patient's fingers, and then you tap on the examiner's hand, it causing a sudden stretching of the flexed fingers, and you may get a jerk. And finger jerks are really a sign of an upper motor neuron lesion. They don't occur in normal healthy people. You won't get them in a normal state. Similarly, supinator jerks are not usually very obvious in a otherwise healthy person. So those are the root values of the reflexes, and then the final thing to look at is the dermatomes. And the dermatomes relate very well, the sensory parts of course, to the motor, and we've talked about the brachial plexus, and so it's not surprising that C5 to T1 dermatomes occur in the upper limb.
The dermatomes of the arm correspond with the roots of the brachial plexus. The brachial plexus runs from C5 to T1, so the dermatomes of the arm correspond to that. So if we just look at, I've sketched them out here, and this is a slightly simplified version of the actual distribution of the dermatomes, but it's good enough for practical purposes for what we need. Okay, so let's start. So the C4 is up on the shoulder, of course, corresponding with the phrenic nerve and a referred sensation from the diaphragm. And then when we get into the arm proper, on the outer lateral border of the arm, we have C5 first of all, and then from the elbow downwards we have C6 that runs down to the thumb and the index finger. C7 picks out the middle finger and perhaps some more. C8 on the inferior border of the forearm, and then finally T1 on the inferior border of the upper arm and perhaps below the elbow as well. And so that's the dermatomal distribution within the upper arm. And then if we come back to the chest, we had C4 across the shoulder, and then because C5 to T1 have all been in the arm, the next dermatome is actually T2.